Hello, everybody. I'm Carmen Pugliafito, and I'm here today with Dr. Dilsher Dhoot from the California Retina Consultants, based in Santa Barbara, California. And we're going to talk about Dr. Dhoot's presentation at the Angiogenesis 2021 meeting, where he gave some new data from the PANORAMA trial. Dilsher, would you like to tell us about your presentation?
Yeah, thank you for
synthesis.
Sure, thank you for having me, Carmen. It's great to be here with you this morning. This is actually very interesting data. This population of patients that have diabetic retinopathy, there's been a fair amount of data looking at two-step improvements with anti-VEGF therapy. But who to treat, and why does it even matter? Well, vision-threatening complications like center-involving diabetic macular edema and proliferative diabetic retinopathy or anterior segment nevascularization. We know these complications can occur at a more frequent rate in this population, specifically those patients that have moderately severe or severe non-proliferative diabetic retinopathy. And this was exactly the population that they looked at in the PANORAMA trial. And so we looked in a post hoc fashion, and we asked the question, can we further risk stratify this population based on angiographic features? And there's really two angiographic features that we could look at. One is baseline non-perfusion, and the other is baseline leakage. And so we asked, if we look at these two baseline angiographic factors, do we see differing rates of VTC or center DME incidence in the sham group versus the aflibercept group? And it turned out that there was. It turned out that as you had increasing baseline leakage or increasing baseline non-perfusion, there was an increasing trend in the sham group only, but not in the aflibercept group. And it turned out the aflibercept group had lower rates of VTCs or center DME compared to the sham group, irregardless of baseline non-perfusion or baseline leakage.
So what was the way the reading centers graded the non-perfusion? How did they do that?
So they had unmasked readers that evaluated the ETD 7-field ETDRS angiograms. And so that's probably one thing that I would change about this trial. I would love to have had wide field angiographic data. This was 7-field ETDRS, and they measured these in a manual fashion. And there were two readers, and if there was a difference, then a third reader would adjudicate that.
Is this consistent with prior studies that have been done looking at non-perfusion and vision-threatening complications?
Yeah, there's not been a whole lot of studies looking at this specifically. Certainly, we've looked at with Charlie the similar angiographic findings in Vivid and Vista and Rise and Ride, and those have also been 7-field ETDRS.
So, what are you doing today in your clinical practice with eyes with non-proliferative diabetic retinopathy? How are you treating them?
It's a tough population because a lot of times it's a well-sighted population and they can have profound angiographic changes. And you especially if they have good vision in both eyes, I start to plant the seed that there is a therapy, anti-VEGF therapy, that could certainly help improve the look of things. Ultimately for the patient, they're wondering why does it matter? And so you have to have some level of buy-in that these patients are at risk for decreased vision over, say, the course of a year. So I begin to plant the seed, and eventually, a lot of patients will start to consider anti-VEGF therapy. Certainly, if the fellow eye has been affected with DME or proliferative diabetic retinopathy, they're more apt to receive a treatment or consider treatment. I think the PANORAMA data was very helpful, so we could see that the treating these patients, even on a Q16-week basis, is much more palatable than say monthly or every 8 weeks.
So in the real world clinical situation, are you doing it every 2 months, every 4 months?
I might start doing it every couple months, and then I actually will extend it out to every 4 months or so, just based on the PANORAMA data. We can see that there's that risk reduction that's still quite marked at every 4 months. And I think that for patients that have good vision, it's just easier for them to tolerate.
So the results aren't surprising that the more non-perfusion you have, the more diabetic macular edema and vision-threatening complications you develop. Were there any findings that were surprising?
There was some interesting data when we looked at ethnicity. It turned out that in African American populations, it was almost like the inverse. The more non-perfusion you had, there was a higher proportion of African American patients that seemed to have more non-perfusion. But then when we looked at baseline leakage, it was kind of the alternate. It was the greater the baseline leakage, there was a lower proportion of African American patients. And so that was the only ethnic trend that we saw when we looked at the data. Aside from that, I think that the data was intuitive. I mean, like, for the most part, it kind of followed along what you might think. But it does give us, some further way to risk stratify. Certainly, the question has come up: is it worth treating these patients that have good vision? The talk prior to mine by Jenny Sun, asked that same question. And I think that if we're able to further risk stratify these patients, it may very well be worth treating these patients. You can imagine one day when there's, artificial intelligence that can help us read these angiograms in a more quantitative fashion, that it will be even easier to risk stratify the patients.
So is there a practical way of identifying patients that are at higher risk, looking at more eyes with more extensive non-perfusion or leakage? Those are the ones that you should consider intervening in?
Yeah, I think it's kind of it's a gestalt, right? When we look at the angiogram, we don't have software yet that can actually quantify it for us, these variables in an easy fashion. And so I think you have to, you look at the angiogram. If there certainly is some level of non-perfusion that's visible easily, I think that patient's at higher risk, and certainly it makes sense to consider treating that patient. We see profound leakage. That's also a patient that potentially we'd want to treat earlier, rather than patients that may have findings that are consistent with moderately severe or severe NPDR, but really don't have those baseline characteristics.
Well, Dr. Dhoot, thank you so much for your participation in the retina synthesis program, and a very interesting set of data, and more to come, I'm sure. Thank you for being with us.
Thank you for having me, Carmen. Appreciate it.